You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 24th, 2021. This week, dual antiplatelet therapy, the full Samson trial published, Nightshift Work and Atrial Fibrillation, and a cautionary note on therapeutic enthusiasm in the treatment of patients with heart failure. First, a note on COVID. Overall, the U.S. numbers are down, but the story in the U.S. is geographic. Case numbers in states like Texas and Florida are dropping, but places like Alaska and Idaho are still seeing high numbers. We, fortunately, here in Kentucky are seeing a decrease in our numbers. I really hope that after Delta and with vaccinations, we'll see a dormant period. I can't wait for the pandemic to be over, so perhaps we can all be friends again and go back to arguing over anticoagulation, and TAVR, and stents, and biased observational data, and even appendage closure. That's it for COVID. Let's go straight to cardiology. The Master DAPT trial. At ESC, we learned the results of the Master DAPT trial. This was an RCT that compared an abbreviated and non-abbreviated strategy of dual antiplatelet therapy, or DAPT, after drug-eluting stent placement in patients who were at high bleeding risk patients. New England Journal of Medicine published the trial, and Dr. Marco Valgamigli was the PI. Now, even if you don't do interventional cardiology, hang in here because there are some nifty lessons on non-inferiority testing that I'll mention. Now, first, some background points. Patients with high bleeding risks actually represent about a third of patients who come for PCI. I actually didn't know that. I won't go through all the high bleeding risk criteria, but these things include like use of oral anticoagulants, recent bleeding episodes, age greater than 75, systemic conditions such as low platelets, anemia, steroid use, nonsteroidal use, and something called the precise DAPT score with greater than 25, and this is a 5-item risk score using clinical criteria. Now, the stent used in Master DAPT was a drug-eluting stent that's not available in the U.S. And patients were a mix of acute and chronic coronary syndromes. About 50% were ACS. About a third, 36%, were on oral anticoagulants, and the mean age of these patients was 75. The two strategies tested started after 1 month of DAPT. Both groups got 1 month of dual antiplatelet therapy, and one group had the DAPT stopped right there at 1 month, and the other had DAPT continued for another 2 to 5 months. The mean duration of DAPT in the abbreviated arm was 34 days and 193 days in the standard arm, so a big difference in dual antiplatelet therapy. The outcomes measured, there were 3 ranked primary outcomes. The first one was something called net adverse clinical events, which is all-cause death, MI, stroke, and major bleeding. The second outcome was MACE, basically major adverse cardiac or cerebral events, death, MI, and stroke. And the third outcome was the safety outcome, major bleeding. The first two were tested for non-inferiority and the third superiority. 4,400 patients were randomized. The type of single antiplatelet therapy in the abbreviated group was clopidogrel in 56%, aspirin in a third, and ticagrelor in 14%. So here are the results. For net adverse clinical outcomes, anything bad, 7.5% versus 7.7% abbreviated versus non-abbreviated. That met non-inferiority. For the major adverse cardiac outcomes, 6.1% in the abbreviated arm, 5.9% in the standard arm. So again, met non-inferiority. Major bleeding, however, 6.5% versus 9.4% in the standard arm, an absolute risk reduction of 3%. So that was highly significant for superiority. And it was driven actually by lesser severe bleeds, which I'll talk about coming up. The limitations of this trial, it's an open label. The DAPT duration varied in the standard DAPT group, but that reflects clinical practice. The DAPT duration in both arms was longer than what is currently recommended in patients who take oral anticoagulants. The ESC guidelines favor 1 week of DAPT plus oral anticoagulants. The study was not designed to assess the role of the type of single antiplatelet therapy after stopping DAPT. The non-inferiority margins were wide. Observed event rates were lower than expected, and that's one of the things I'm going to focus on. And the results may not apply to patients treated with other stents. So in a discussion of this, the comments, this gets a little tricky, but I really think it's important. The first endpoint, net adverse clinical events, had both efficacy, so thrombotic events, and safety, bleeding events, which you'd expect to trend in different directions. Now, when you have things trending in different directions, that's going to make non-inferiority easier to reach, right? Because no difference in non-inferiority is a positive finding. Now, the reason trialists do this is that having more endpoint events gives the trial more power and thus requires fewer patients. There's always this tension in trials because of ethics, experimenting on as few patients as possible, and of course, cost. I mean, trials are expensive. The editorialist, Dr. Magnus Ullmann, made another important point about the non-inferiority testing used in MasterDAPT. Now, his point was that non-inferiority was met in the first endpoint, the net adverse clinical events, but it was driven by less bleeding. Now, the problem was that the observed rate of events was far lower than expected. Well, why is that important? It's important because the non-inferiority margin was set at an absolute risk difference of 3.6%, meaning if the upper bound of the event rate in the abbreviated arm was less than 3.6, then it could be called non-inferior. But that 3.6 number is based on an event rate of 12% in the control arm. But that is not what was seen. Instead, the event rate was 7.7%. And that's important because 3.6% margin represents a much larger proportion of 7.7% than it does of 12%. Now, Sanjay Kaul from Cedars-Sinai had a nice Twitter thread on this from August 30th. And by the way, this was also the problem in the Watchman versus Warfarin trials. Now, the low event rate also affected the non-inferiority of the second endpoint, the major adverse cardiac events. The non-inferior margin here was set at 2.4%, and the expected event rate was 8%. But instead, the observed event rate was 5.9%. So again, the 2.4% margin is a larger proportion of 5.9. So while the actual MACE event rates look similar, 6.1 versus 5.9, the upper bound could have included up to a 30% higher incidence of events in the abbreviated arm, which is pretty worrisome, right? 30% higher rates of major adverse cardiac events and still non-inferior. Okay, but a proponent of the abbreviated strategy could say major bleeding was significantly less, and that's true. But the difference here was driven by less severe bleeding episodes. The more severe types of bleeding were similar in both groups. Before I conclude, let's just talk about a sub-analysis of MasterDAPT that was also published in a separate paper in Circulation. And this paper analyzed the results for the two strategies with patients who had an oral anticoagulation indication. Now, that was 36% of the patients. The abbreviated and non-abbreviated arms here were a bit different. In patients with an oral anticoagulation indication, the abbreviated arm was to stop DAPT after 1 month, then go to single antiplatelet therapy for 5 months, then oral anticoagulation alone for up to 11 months. And in the non-abbreviated arm and an oral anticoagulation indication, DAPT was continued for 2 months, a total of 3 months, right? 1 plus 2, then single antiplatelet therapy along with oral anticoagulation thereafter. Now, first finding that with the abbreviated strategy, the occurrence of ischemic and net events did not differ in patients with and without oral anticoagulation. Stopping DAPT at 1 month and continuing with single antiplatelet therapy reduced bleeding significantly in patients without an indication for oral anticoagulation, but it wasn't significant in patients with an indication for oral anticoagulation. It was numerically less, but not significantly less. Journalist Sue Hughes has fantastic coverage, and she includes slight differences of opinion on the reduction of bleeding. Mainly that the abbreviated strategy only had a significant signal of less bleeding on those without an oral anticoagulation indication. So what can we say overall about MASTER-DAPT? I like the trial because even if you don't do PCI, the non-inferiority analysis makes you think hard about how we measure outcomes. But I'd say the trial creates many more questions than answers. I mean, can we extrapolate these data to other stents? I think that's the main one. And do we really feel comfortable with those non-inferiority margins given the lower than expected event rates and the safety signal mostly seen in non-severe bleeding cases and mostly in patients without an oral anticoagulation indication? Surely nothing about MASTER-DAPT moves us toward an easy algorithm of antithrombotic regimens after PCI. The choice of how best to deal with a metal cage in the coronary artery remains something that must be individualized. The tension between reducing bleeding but not increasing thrombotic events remains, and it remains tricky. Now, at the risk of making people mad, and God knows it won't be the first time, I'll remind readers that only half of the patients in this trial had an ACS indication. And in stable patients, we have oodles of data that cast doubt on the treatment of focal stenosis for the reduction of MI, death, or even angina. So of course, the best way to avoid having to balance thrombotic and bleeding complications post-PCI is not to have a PCI in the first place. For ACS syndromes, of course, it's a no-brainer, but for stable patients, there's room to think hard about indications. Next topic is the full Samson trial was published. A little less than a year ago, researchers at Imperial College London, the first author James Howard, presented at the American Heart Association the results of the N of 1 Samson trial. This was a crossover trial in which patients either took a statin, a placebo, or no pill. The self-assessment method for statin side effects or nocebo trial, Samson, was published in letter form then in the New England Journal of Medicine. This week, the Journal of American College of Cardiology has published the full paper, including the patient-level results. Now, last November, I felt like this was one of the most important trials of the year, and the full publication bolsters that view. To briefly recap, Samson enrolled about 60 patients who had previously abandoned taking statins because of intolerable symptoms. These patients had no intention of restarting statins. Many of the enrolled patients have been tried on different statins and different doses. The most common symptom before enrollment were muscle aches in about 60%, but also fatigue, tiredness, and cramps. The protocol was unique and elegant. Patients received 12 one-month bottles. 4 bottles contained atorvastatin 20, 4 bottles contained a matched placebo, and 4 bottles contained no pills. Patients were instructed to record daily symptoms intensity on an app. The scale was 0 to 100. The primary outcome of interest was the nocebo ratio. That's the ratio of symptoms induced by the statin that was also induced by taking the placebo. Now, before I tell you the results, we should review 5 important background points. First, in blinded statin trials, and there's been oodles of them, the incidence of nuisance side effects, mostly statin-associated muscle symptoms, are similar in the placebo and statin arms. But in observational studies, which are not blinded, the incidence of statin-associated muscle symptoms are higher in those who take statins. Now, while we can argue about the effect size of statins in absolute terms, these are the most studied drugs, and they deliver a remarkably consistent 20 to 25% reduction in future cardiac events. But most people who start a statin end up stopping the drug, usually because of side effects. That's what makes this so important. Also, regression to the mean is a really important concept here. We docs often do mini trials of statins, but the problem with our little experiments with patients is that statins are often stopped when symptoms are maximal and they would naturally decline, and statins are restarted when symptoms have resolved and can only get worse. And of course, the final point is that middle-aged people have lots of fluctuating aches and pains, and I can testify to that. So the findings. The main finding is that the marginal mean symptom score was 8 during the no tablet months, 8 out of 100. It was 15.4 during the placebo months, which was significantly higher than the no pill months. And it was 16.3 during the statin months, which was also significantly higher than the no pill months. But the difference between the placebo score of 15.4 and 16.3 were not at all statistically significant. Now imagine a bar graph with a symptom score on the y-axis. The score of 15.4 is about the same as 16.3, and so the nocebo ratio was 0.9, or in other words, nearly all of the ill effects of taking the statin came from taking the pill as much as taking the statin chemical. Now, we knew this from the New England Journal of Medicine letter last November, but the full paper had some other additional features. For instance, there were similar numbers of participants who stopped taking the statin as the placebo. Intensity of symptom onset did not predict whether the pill was a statin or placebo. The magnitude of symptom relief did not predict whether the pill was a statin or placebo. And after the trial was over, 30 of these 60 intolerant participants in the trial had restarted their statin. And review of individual patient data that the authors gave us revealed 3 patterns. Some patients experienced no adverse effects during the trial, despite being intolerant before the trial. Some patients had intense symptoms throughout, regardless of whether they were taking pills or not. And the most common pattern was that symptoms increased with both the statin and the placebo. My comments here is that this study has 3 big implications. First, it shows the power of the nocebo effect. Clearly, the major source of adverse effects was simply the act of expecting adverse effects, not so much from the statin chemical. This has major repercussions for how we interact with patients. Our words can harm or they can heal. While it is surely right to explain potential adverse effects of therapies to patients, it is also important to understand that expectations matter. I, for one, have discussed this trial numerous times with patients. And the same issue comes up with other drugs, such as like beta blockers. Negative expectations surely play a role in some of the side effects of these meds as well. I tell patients who are going to take a beta blocker that they're illegal performance-enhancing drugs in golf. A second important implication revolves around regression to the mean and the dangers of current practice of informal experiments of taking patients off and on the statins. The problem is that statins are often stopped when symptoms are maximal, and that would be, if they're maximal, they'd naturally tend to decline. And then we restart statins when symptoms are resolved, and therefore they can only get worse. Thus, the prompt onset and offset of symptoms after starting and stopping pills is often interpreted by docs and patients as evidence of causation. Sampson shows that this was true, but the patterns were similar for both statin and placebo, and this is why the no-tablet months were so critical. Current practice, therefore, could be entraining a nocebo response. Finally, there is a lot of background noise when it comes to generalized complaints like muscle aches and fatigue. In Sampson, sometimes intolerant patients could restart without trouble, and other times patients felt bad no matter what they were taking. Senior author Daryl Francis has told me that placebo pills are super expensive to make, and drug companies have no incentive to make them. So Sampson-like trials are not going to be practical for individual docs and patients, though I wish they were. That said, Sampson is a worthy trial to keep front and center in our brains and in our clinic drawers because it reminds us of the massive complexity of our doctor-patient interactions. Next topic is Nightshift Work and AF. A large group of authors from US, China, and Sweden have published an interesting paper in the European Heart Journal on the association of nightshift work and AFib and coronary heart disease. The data source was the UK Biobank. The analysis included about 276,000 individuals who did not have CHD, stroke, heart failure, or AFib at baseline. Follow-up was 10 years, so a long follow-up. And there were a lot of episodes of AFib, almost 6,000 episodes. And the authors created 4 categories: day workers, shift workers with rare night shifts, some night shifts, or like permanent night shift work. The control arm was the day workers. And those who worked at night more often had lower socioeconomic class, lower education level, they worked longer hours, and reported shorter sleep durations. So here are the findings. Compare with day workers. increasing categories of night shifts were associated with a higher risk of incident AFib in age and sex-adjusted models, and rotating shifts with usual or permanent night shifts had the highest risk. So that was 1.16 hazard ratio, confidence intervals 1.02 to 1.32, so a 16% increased risk of AFib. And the association remained significant after adjustments for demographics. The authors also looked at coronary heart disease and stroke and heart failure and found that the usual permanent current night shifts were significantly associated with a higher risk of CHD. The hazard ratio here was 1.22, but there was no relationship with heart failure and stroke. The authors then did something called a PAR, population attributable risk, which is the amount of AFib that if this were a causal relationship, this is only theoretical because it may or may not be causal, but if it were causal, the amount of AFib that would be eliminated by eliminating shift work, and the PAR here was only 1.7% for AFib over 10 years. That's pretty small. For comparison, the population attributable risk for smoking exposure and lung cancer is 80%. My take of this study is that I'm surprised the association was so weak. I've seen a lot of patients whose AFib improves when they either go to day shift or retire. The coronary heart disease signal looked even stronger. Also, disordered sleep has a clear association with AFib, and night shift work often leads to sleep abnormalities. So when I saw the headline, I thought, yep, this is going to be a big association. But it ended up being a pretty weak signal, one that barely reached significance after adjustments. I think the message here is that there are likely many causal factors in AFib, and shift work is likely one of these many. Also, the normal caveats of observational studies apply. The authors can only adjust for things on a spreadsheet, and people who work nights may have characteristics not captured on a spreadsheet. Also, these sorts of studies use self-reported data, so there may be recall bias. And UK Biobank also may have a degree of healthy volunteer bias and may not represent the average shift worker. Nonetheless, I still think we can recommend that patients strive for the best sleep hygiene they can achieve. A final, very brief topic on some therapeutic fashions I see changing in heart failure. Journalist Mitchell Zoller covered a session at the Heart Failure Society Association meeting in which a number of trialists and noted heart failure experts opined on expanded use of sacubitril valsartan and SGLT2 inhibition in heart failure. There were like 3 points made. First, ejection fraction is not valuable. Forget about it, said Dr. Milton Packer. Specifically, that 40% cutoff, and the others agreed. One suggestion came forth, quote, wouldn't it be easier if we said that every patient with heart failure needs to receive one agent from each of the 4 pillar drug classes? Now, a second point that Dr. Packer made that strain, LV strain, is going to be a better measure of systolic and diastolic heart failure. And the third point was, never mind these trials with non-significant primary endpoints like Paragon and CHARM and TOPCAT. If we instead focus on post hoc analyses of certain patients, we can find significant benefits of the drug. I worry about these 3 sorts of arguments. Here is why. The drugs they are proposing to use are costly, and I would argue, based on the trial results, probably of low value. Second, while I'm learning a lot about strain, the problem is that no trial used LV strain as an entry criteria. And so for better or worse, EF is the established measure. I mean, strain may become a useful surrogate, but it isn't there yet. I'd ask you, try getting an ICD approved on strain, SCAR, or anything other than EF. Now you might say, come on, Mandrola, don't you want to do what's best for your heart failure patients? And I do, but we also have to stay clear-eyed about the evidence. And here is a brief summary of how weak it is. Sacubitril valsartan in heart failure with reduced ejection fraction. Now remember, the comparator in Paragon HF was a medium dose enalapril. Did sacubitril valsartan crush it in that trial because it was great or because enalapril was weak? Now Packer and other heart failure experts shun this argument, but since then, every time sacubitril valsartan gets compared to valsartan alone, it looks a lot less impressive. I'd love to see a Paradigm HF trial repeated with valsartan as the comparator. All right, what about sacubitril valsartan in HFpEF? Now remember that Paragon HF missed its primary endpoint. The FDA approval rests on subgroup analysis of a trial with a non-significant endpoint, which can be justified, but mostly for generation of hypothesis for future trials. What's more, in Paragon, there were no differences in CV death or overall death, despite a high death rate of 14% in both arms. Okay, what about empagliflozin in heart failure with preserved ejection fraction? Again, the only thing this drug did was reduce heart failure hospitalizations. No difference in CV death, or quality of life. Also, we weren't given baseline loop diuretic use in the two groups, and heart failure hospitalization was just a small fraction of total hospitalizations. Thus, we can say that for those with heart failure and reduced ejection fraction, yes, RAS inhibition, beta blockade, SGLT2 inhibition, and MRA use, along with CRT and ICD therapy in indicated patients are clearly beneficial. Are the new drugs, though, as good as the old? I am not totally convinced. And in a larger group of patients with heart failure and a better ejection fraction, compelling data for use of super expensive drugs as a routine, I think is sparse. Yes, specific patients may benefit, but I don't think we are anywhere near instituting an algorithmic pathway or quality measures for patients with heart failure and preserved or mid-range ejection fraction. So that's it for this week in cardiology, and I want to say thank you to those who are leaving comments on the heart.org Medscape Cardiology website. And remember, friends, if you listen to this on another podcast app, please take the time to give us a rating or write us a tiny little review. Those sorts of things really help others find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.